Hello, everyone. My name is Corey Thornton. I'm the senior editor here at Open Minds, and welcome to today's Circle Executive Roundtable, doubling down on whole person care, advancing integration through the CCBHC and IBH models. Today's roundtable features Open Minds senior associates Deanne Cornett and Christy Dye. Before we get started, I have a couple of housekeeping reminders. Your audio is muted for today's briefing. However, if you have any questions, we encourage you to submit them using the question box located on the right side of the screen, and we will answer those after the presentation. And finally, the slides and the recording for today's roundtable will be archived and available for elite members on the Open Minds website starting tomorrow, Friday. With that, here's Dan and Christy.
Hi, everyone. Welcome to today's webinar. Christy and I have been working to bring you the most up-to-date information on whole person and integrated care to help maximize your services to improve patient outcomes and streamline your costs. In today's session, we'll explore how both the Certified Community Behavioral Health Clinics, or CCBHCs, and the Innovation in Behavioral Health Model, or IBH, are transforming the delivery of behavioral health by emphasizing whole person care. These models are designed to integrate mental health, substance use, and primary care services, addressing the full spectrum of patient needs. Through this lens, we'll discuss how these approaches are not only to improve health outcomes, but also tackle the social determinants of health that impact patient well-being, such as housing, employment, and access to food. We can go on to the objective slide, Christy. There we go. By leveraging these integrated models, strategies, and evidence-based practices, healthcare organizations can position themselves to deliver more coordinated, comprehensive care that improves both individual and population health. On the next slide, we'll look at a brief overview of whole person care. Whole person care is an approach that considers various factors influencing overall health, such as social and environmental conditions, health behaviors, physical health, and mental or behavioral health. Integrated care is a delivery model, structure services to support this comprehensive approach by enhancing collaboration across disciplines, adopting new technologies and payment models, and ultimately improving consumer outcomes. Whole person care and integration are core principles in the frameworks of CCBHCs and the IBH model. Just an overview, we can stay on this slide, Christy. CCBHCs emphasize a comprehensive person-centered approach to behavioral health care by addressing not only mental and behavioral health, but also physical health, social determinants, and health behaviors. CCBHCs ensure that patients receive holistic care. Integration is key to the CCBH model, with a focus on breaking down silos between physical and behavioral health services. This is achieved through team-based collaborative care, ensuring that services are not just co-located, but also coordinated, with the goal of improving outcomes and expanding access to care for vulnerable populations. The IBH model similarly promotes the integration of services, particularly through the use of innovative delivery methods such as technology, data-driven care, and value-based payment structures. It fosters improved outcomes and collaboration among providers, helping align care with patient needs while promoting efficiency. By integrating care within these models, both CCBHCs and the IBH model aim to provide whole person care, emphasizing those things that we mentioned, mental, physical, and social health as interconnected elements of well-being. On slide 6. Why would we want to consider whole person care? Of course, whole person care is a holistic approach. It addresses the complex consumer needs required for a comprehensive approach that goes just beyond treating individual symptoms or conditions. We're also looking at coordinating and integrating various supports that are individualized, as well as implementing those outcomes or those services that lead to improved health outcomes, reduced healthcare costs, and increasing patient satisfaction and overall well-being. And there is a value to whole person care. On the next slide, we'll look at specifically payers. Managing costs becomes crucial as 10% of the US consumers use 70% of healthcare resources, and greater investments in addressing social conditions such as housing, food, and transportation, which account for 50% of health outcomes, can lead to more efficient resource use. For providers, managing care involves taking ownership of more services to leverage better outcomes. This increases their control over service delivery, population management, and costs, while also enhancing their capacity to assume risk in care delivery. The next slide. Thank you, Christy. Of course, the healthcare landscape is evolving. It's driven by several key market forces. Firstly is financial sustainability. It's no longer guaranteed, and new competitors are disrupting traditional specialty care by capturing large segments of the market. Telehealth and other tech-based care models are offering faster, more accessible services directly to consumers in their homes. And there's also an increased focus on whole person health solutions with more investment in addressing social conditions, those conditions that we talked about earlier. And those solutions present new opportunities in complex consumer markets. And payers are increasingly preferring the integrated whole person care approaches. Meanwhile, health plans are shifting their focus to paying for value. They're becoming what we call payviders, competing with traditional health plans while emphasizing performance-based reimbursement. For behavioral health, this means demonstrating how improved services lead to reduced ER visits and hospital readmissions. These result in savings for primary and acute care. However, patient attribution challenges within behavioral health are driving efforts to load these value payments into primary care's per member per month rates. And on the next slide, Christy and I developed ways to help organizations move or enhance a whole person care. And as we've done this, we've found more than 80 ways to integrate care. And these avenues can lead to numerous strategies that providers can use to break down the barriers between physical and behavioral health services. And by integrating that care, organizations can deliver more comprehensive, coordinated, and patient-centered services that address those needs. The framework highlights practical steps for integrating care across various service lines, including leveraging new technologies, coordinating interdisciplinary teams, and adopting value-based payment models. The goal is to create seamless care experiences for patients by improving collaboration among providers, increasing access to care, and ensuring their health outcomes are enhanced across all areas of the patient's life. Next slide, please, Christy. By integrating care across multiple providers and disciplines, whole person care improves rapid access, patient convenience, and health outcomes. Whole person care addresses the social drivers of health, and those things influence 70% of health outcomes. High risk, high cost patients, who make up 10% of the population, account for 60% of healthcare spending, and that's important to reiterate as we move forward with this process and the considerations that we have in determining which route to take. Whole person care prioritizes data-driven care to support preventative services and reduce unnecessary utilization. Integrated care providers utilize advanced technologies. They improve care coordination and enable greater control over their service delivery. And most value-based contracts focus payment on the primary care component, giving providers more leverage to assume financial risk. On the next slide, we look at the history of CCBHCs and how it came to be. The Excellence in Mental Health and Addiction Treatment Act established a federal definition and criteria for expanding to CCBHCs, which receive an enhanced Medicaid reimbursement rate based on their anticipated cost of expanding services to meet the needs of vulnerable populations. And In 2014, this was first authorized under the Protecting Access to Medicare Act. In 2015, the certification criterion for states were awarded through Medicaid planning grants. And in 2017, the first 8 states began the Section 223 Medicaid demonstration. In 2018, the first 52 CCBHC providers expansion grants were awarded, and in 2020 to 2021, states began adding CCBHC programs through Medicaid state plan amendments and waivers. In 2023, the criteria for certification was revised, and most recently in 2024, an additional 10 states began participating in the Section 223 Medicaid demonstration. Next slide, please. So our certified community behavioral health clinics, they must meet the certification standards for services provided, which means they're required to get people into care quickly and coordinate care through those agreements and other healthcare entities, which include hospitals. They must serve anyone. They must do this 24/7 crisis services, either directly or through an arrangement with an existing crisis network. They must provide primary care screening and monitoring of health conditions, and utilize the Medicaid prospective payment model based on total annual allowable cost, direct and indirect expenses. And this includes a quality bonus payment program using HEDIS measures. And the last bullet here, while only a few states currently participate in the Medicaid PPS demonstration, half of states require their Medicaid health plans to cover services delivered by CCBHCs. Next slide, please. There are the 9 core services that are required that a CCBHC provides, and that includes crisis service, outpatient mental health and substance use services, person and family-centered treatment planning, community-based mental health care for veterans, peer family support and counselor services, targeted case management, outpatient primary care screening and monitoring, psychiatric rehab services, and screening, diagnosis, and risk assessment. Next. And these can be funded through 3 primary sources, and that would be the SAMHSA CCBHC grant program, the CMS Medicaid demonstration program, and the independent state Medicaid programs. And it's noted here that funding covers the 9 core CCBHC services, but does not cover the primary care service delivery. Our next slide, please. Those providers that are eligible to become CCBHCs include community-based behavioral health nonprofit organizations, and these organizations are either part of a local government behavioral health authority or operated under the authority of the Indian Health Service, an Indian tribe or tribal organizations, or they are an urban Indian organization pursuant to a grant or contract with the Indian Health Service under Title V of the Indian Healthcare Improvement Act. Next. Our SAMHSA CCBHC care delivery framework includes the 9 core services which we just reviewed, and expanded access to care, serving those who need services regardless of their ability to pay. And it aims to increase access to care by expanding service locations using telehealth and providing transportation assistance. And there's also a whole person care focus, taking a holistic approach to coordinating physical, mental, and health and substance use services, and also including family and peer support to address the needs of the whole person. And there's also a focus on care coordination. CCBHCs are required to develop partnerships and care coordination agreements with other providers to ensure seamless integrated care for their patients. And then CCBHCs operating in the Medicaid demonstration are reimbursed through a prospective payment system, or PPS, that is based on costs of delivering services and provides a stable, predictable funding source to support their comprehensive service model. So that's what the CCBHC care delivery framework looks like. Let's go to the next slide, Christy. There are benefits and challenges to the CCBHC implementation and consideration. Improved access to comprehensive coordinated care for individuals with complex needs is a major benefit of the CCBHC model. It promotes greater integration of primary care and behavioral health services. It ensures that patients receive more holistic care. And this model also enhances the recruitment and retention of behavioral health professionals while expanding workforce roles to include a more diverse array of specialists. And in addition, CCBHCs are designed to offer expanded crisis services, which are essential for addressing urgent behavioral health needs. However, there are challenges. Meeting CCBHC certification requires significant upfront investment, from infrastructure to staffing. Coordinating care across multiple providers and systems can be difficult, and there's often a steep learning curve in delivering and sustaining evidence-based practices. Billing for contracted services and upgrading electronic health records and billing systems to meet quality reporting and payment requirements are also hurdles that organizations must address in order to fully implement and benefit from the CCBHC model. And slide 19 will do just an overview of the Innovation and Behavioral Health Model, or IBH. It really propelled the industry towards value-based care and further integration with the rest of the healthcare system. And this, as a new model, is an effort by CMS to really marshal public resources into coordinated whole person care for individuals with severe behavioral health issues. Specifically, this model connects adults with mental health conditions or substance use disorders to physical, behavioral, and social supports, prioritizing a collaborative care model between behavioral health and physical health providers. And this model also takes a different slant than most integration programs. Instead of integrating into behavioral health, you're looking at moving more towards physical health and social supports being integrated into behavioral health. And this is becoming more increasingly common in mainstream healthcare. And this new program also conceptualizes really the end game of integration efforts. Individuals with moderate to serious addiction or mental health issues often face aggravating physical health issues, and to worsen each other, and when siloed as they are today, behavioral health and physical health providers cannot address the totality of a patient's needs. And this model also seeks to empower state-level officials to create healthcare hubs within behavioral health provider organizations that addressed behavioral health, physical health, and social support needs. So all of this is very recent. In January of 2024, CMS announced the Innovation and Behavioral Health Program. In June, the first notice of funding opportunity was released for state Medicaid authorities. And in September, applications by state Medicaid authorities were due, and the expectation that those awards would be made by December. And then looking forward into the next year, there will be infrastructure and capacity development necessary to deliver integrated care. And then upwards towards 2028, we'll be looking at the implementation of the IBH model for Medicaid population and begin initiatives to address health disparities. So much has happened in the past year, and much continues to happen in the future, we'll see as we move forward, learning more about what IBH means for us and how we can implement it, and also how it will improve our care. And the next slide. The model has key objectives aimed at transforming care for individuals with mental health and substance use disorders. Its primary goals include integrating behavioral health services with primary care to create a more cohesive whole person care approach to treatment. By doing so, this model seeks to improve access to care, particularly for underserved populations, while also enhancing the quality of care delivered. And the intended outcomes of the model are to reduce avoidable hospitalizations and emergency department visits, lower overall healthcare costs, and improve patient satisfaction and clinical outcomes. By emphasizing preventative care and care coordination, the IBH model fosters more consistent and efficient management of behavioral health conditions with a focus on reducing gaps in care and addressing social determinants of health. This in turn supports long-term health improvements and sustainability for patients and providers alike. The next slide, please. The Innovation in Behavioral Health Care Delivery Framework is designed to enhance the quality of care for individuals with mental health and substance use disorders through three key components: care integration, care management, and health equity. Care integration focuses on aligning behavioral health services with primary care to provide a seamless patient experience. This approach ensures that individuals receive comprehensive care that addresses both their physical and mental health needs, thereby improving health outcomes and fostering patient engagement. Care management involves proactive outreach and support for patients, particularly those with complex needs. This includes personalized care plans, coordination among providers, and ongoing monitoring to ensure that individuals receive appropriate interventions and resources tailored to their specific circumstances. And lastly, health equity is a fundamental principle of the IBH framework. It emphasizes the need to address disparities in healthcare access and outcomes among diverse populations by prioritizing social determinants of health and ensuring culturally competent care. The IBH model aims to create a more inclusive healthcare system that meets the needs of all individuals, regardless of their background. Together, these components contribute to a holistic approach that promotes better health outcomes, enhances patient satisfaction, and reduces barriers to care for those vulnerable populations. And in the next slide, we'll look at funding sources for the IBH model, which are really critical to enhancing the capacity to deliver integrated care. There's infrastructure funding, which provides up to $7.5 million for states and providers to strengthen their ability to implement the model, with a particular emphasis on health information technology and data management. This funding is essential for establishing the necessary infrastructure to support coordinated care delivery. And then there is state-specific Medicaid payment models. These are developed by individual states with assistance from the Centers for Medicaid and Medicare Services, or CMS. These models include a mandatory value-based payment methodology designed to incentivize better health outcomes and cost-efficient care delivery. The third is an optional Medicare payment model. This is also available and designed by CMS to align with the Medicaid model. States that choose to include Medicare beneficiaries in their programs must ensure that the payment structures are consistent across both Medicaid and Medicare. It's important to note that while IBH funding supports three core services, it does not cover behavioral health, substance use, or primary care services directly. This distinction ensures that funding is strategically focused on enhancing the integrated care framework, thereby promoting overall health system efficiency and effectiveness. On the next slide, we'll look at the performance-based payment measures that CMS has established for the IBH model. These measures are designed to assess and enhance the quality of care delivered through integrated behavioral health services. The first that we'll look at is practice measures. They will focus on evaluating the performance of healthcare providers at the individual practice level. These measures include metrics related to patient engagement, treatment adherence, and the effectiveness of care interventions. They are intended to incentivize providers to improve their practices and deliver high quality care to patients, ensuring that the needs of individuals with mental health and substance use disorders are met effectively. State measures are broader metrics developed to evaluate the overall performance of state systems implementing the model. These measures assess the impact of integrated care initiatives on the population health outcomes, accessibility of services, and the efficiency of care delivery across the state. By analyzing these metrics, states can identify areas of improvement, allocate resources effectively, and ensure that the integrated care model is achieving its intended goals. Together, these performance-based payment measures serve as the foundation for accountability in the IBH model, ensuring that providers are rewarded for delivering high-quality, coordinated care that meets the needs of all of their patients. They also help to create a continuous feedback loop for improvement, ultimately leading to better health outcomes and enhanced service delivery in the behavioral health system. Our next slide, speaking to who is eligible to participate in the model. Practice participants must be specialty behavioral health practices, including safety net providers, and must meet specific eligibility criteria at the time of application. Firstly, their practices must be licensed by the state to deliver behavioral health services, which includes either mental health or substance use services. This licensing ensures that providers comply with state regulations and standards for delivering quality of care. Next, practices must meet any state-specific Medicaid provider enrollment requirements and must be eligible for Medicaid reimbursement. This ensures that providers are recognized by Medicaid and can receive payment for the services they deliver to eligible participants. And lastly, participating practices must provide mental health and/or substance use disorder services at the outpatient level of care, specifically to adult Medicaid beneficiaries aged 18 or older who present with a moderate to severe behavioral health conditions. This focus on outpatient services is crucial for addressing the needs of individuals who require integrated care while ensuring accessibility for those who are most in need. By adhering to these criteria, practice participants can effectively contribute to the goals of the IBH model, ultimately enhancing care coordination and improving health outcomes for individuals with behavioral health challenges. Our next slide presents a comparison of key features related to care integration payment between the CCBHC and the IBH programs. Both programs emphasize comprehensive care integration, but there are some differences in their features. Number one being the screening, assessment, referral, and treatment. Both CCBHCs and IBH programs are designed to incorporate screening, assessment, referral, and treatment processes, ensuring that individuals receive appropriate care for their behavioral health needs. And looking at payment for care coordination, both models provide payment for care coordination efforts that bridge behavioral health and primary health services. This coordination is essential for delivering whole person care. In payment for these services, CCBHCs receive specific payments for delivering mental health and substance use disorders or services, whereas the IBH program includes these services under its broader payment model, emphasizing integration with physical health. Payment for physical care services under CCBHCs typically focus more on behavioral health services. However, both models support payments for physical care services to enhance integrated care delivery. and value-based payments. Both models incorporate value-based payment structure to incentivize improved health outcomes and cost-effective care delivery, aligning financial incentives with performance. And looking at focusing on addressing health-related social needs, both programs recognize the importance of addressing these needs and as being essential components of effective care. And then there is a shared commitment to health equity and reducing health disparities. This is central to both models, with strategies designed to ensure all individuals have access to quality care. And both CCBHCs and IBH programs implement quality and performance measures to assess the effectiveness of care provided, which promote accountability and continuous improvement in service delivery. While both the CCBHC and IBH programs share a commitment to integrated care, they have distinct features that cater to the unique needs of their target populations, ultimately aiming to enhance health outcomes and access to care for individuals with behavioral health challenges. Our next slide looks at the operational comparisons between CCBHCs and the IBH model. Both models aim to improve behavioral health care delivery, but they differ in their operational frameworks and implementation strategies. In service delivery structure, CCBHCs are designed to provide a comprehensive array of mental health and substance use disorder services in a single community-based setting. In contrast, the IBH model emphasizes integrating behavioral health with primary care services, facilitating coordinated care across different types of providers. In terms of the target population, CCBHC primarily serves individuals with serious mental illness and substance use disorders, focusing on those who require intensive ongoing support. The IBH model targets a broader range of individuals, including those with mild to moderate behavioral health conditions, emphasizing prevention and early intervention. The funding mechanisms for these, specifically CCBHCs, receive funding through Medicaid to support a wide range of services, including crisis intervention and care coordination. The IBH model utilizes various payment models, including value-based payments that incentivize providers based on performance and patient outcomes. For care coordination, CCBHCs have defined roles for care coordinators who help manage patient needs across the spectrum of services, while the IBH model promotes a more flexible approach to care coordination, integrating care teams across both physical and behavioral health domains. Your data reporting and quality measures for CCBHCs follow specific reporting to demonstrate compliance with state and federal standards, while the IBH model emphasizes a performance-based approach focused on outcomes and patient satisfaction metrics to inform ongoing care improvements. And workforce development, as we all know, is central on our minds right now and has been for several years. With CCBHCs often emphasize building a diverse workforce with specific training in behavioral health, while the IBH model encourages a broader range of providers, including primary care professionals, to engage in behavioral health care delivery. While both CCBHCs and IBH models share the goal of improving behavioral health outcomes, they operate within different frameworks that influence their service delivery, target population, funding mechanisms, and care coordination strategies. Understanding these operational differences is crucial for organizations to implement or engage with either model effectively. And that was quite a bit to cover, and I know Christy is anxious to go on to her section here, so I'll pass it over to you, Christy.
Deanne. Thank you, Deanne, and hello everyone out there. Thanks for joining us for this session. I wanted to turn now to just a couple specific elements in the CCBHC and IBH models. You get very caught up in these acronyms. That you'll really want to consider as you're beginning to plan and thinking about building a whole person care practice. All right. Corey, I'm not getting an advance. Leave off web.
Okay, try now.
Nope.
So down in your lower right, there, if you scroll over it, you should be able to see your arrows.
Yep.
Try those.
Apologies. Nope, Corey.
Okay, can you close the program completely and open it back up? I apologize, everyone. We'll be up and running here in a moment. So if you just close down your deck.
Yeah, so Corey, I'm not able to do that.
Oh my. Okay.
Seems to be frozen. Well, how about if I just talk for a couple minutes and then we'll move on to some questions. So one of the things I just wanted to chat about a little bit were two core components of that are common to both the CCBHC and IBH programs that are important for you all to be thinking about as you move forward with planning an integrated care program. And first up there is really evidence-based practices, and those are required components of both IBH and CCBHC. Under the IBH program, it's really around evidence-based screening, referral, and management for health conditions and health-related social needs. The IBH program specifically requires that participating providers would use the U.S. Preventative Services Task Force guidelines for assessing for 3 core common conditions in the IBH program. That's diabetes, heart disease, and tobacco use. Under CCBHC, most of their evidence-based practices are really ones where specialty care providers are really very familiar with because they're the common core behavioral health evidence-based practices. But related to that, there are also new types of staffing that many of the CCBHC organizations have found they had to implement in order to make evidence-based practices happen. And so in 78% of CCBHC providers, they've actually adopted peer support services as their evidence-based practice. And of course, that requires hiring peer and family support workforce. And in about 30% of CCBHC programs have adopted contingency management, which I think is a lesser known evidence-based practice, but also considered highly effective, particularly with populations with substance use conditions. Then moving on to the types of staff that organizations have commonly adopted in order to support evidence-based practice implementation. When we work with clients here at Open Minds to help them plan and develop and implement a whole person care practice, the really big ones that we see are organizations adopting specific staff that can provide the screening for health-related social needs and those priority health conditions that we mentioned earlier. And often that requires having staff like nurses or medical assistants who can actually draw blood and take other types of samples, which is not something we commonly would do in counseling programs, but that goes along with the line of service in both CCBHC and IBS. Thank you. Yes. Keep going. Keep going. There we go. No, back one, please. Thank you. Perfect. There's also, as I mentioned earlier, a really strong focus on care coordination and of different types. One being the types of care coordinators who can help patients facilitate a transition from the hospital. Usually those are called transition care coordinators or sometimes case management. So people moving from higher, more restrictive levels of care back to the outpatient setting. That's a common type of care coordination. The other one is for those individuals who have complex and often multiple comorbid health, behavioral health, and sometimes social needs that has them going in and out of hospital emergency departments, sometimes being frequently admitted to hospital settings. That's another type of care coordination, and we commonly see our clients that we work with adopting those types of positions. And then finally, the last one I just wanted to highlight, population health data management. It's not uncommon for organizations seeking to implement whole person and integrated care models to need additional new types of staff that are focused on data analytics, as well as the ability to manage data and reporting across, the whole population health spectrum of all the providers that are serving their individuals in order to really focus in on where are those gaps in care we need to close, how are we doing on the specific outcomes we're trying to achieve. Can you move forward 2 slides, please? Trying to also be cognizant of our time. Technology, that's the other area I really wanted to focus in on for just a few moments, because this is another core requirement of both the CCBHC and IBH programs, but it's also fundamental to being able to implement any type of whole person integrated care model. Now in Innovations for Behavioral Health, CMS, I felt, was particularly thoughtful about how they moved forward with their technology requirements, because they really did recognize that most specialty behavioral health providers were never eligible for all of the EHR incentive programs that have been rolling out meaningful use, high tech, over the last 15 to 20 years. So therefore, behavioral health and other specialty care providers never had access to, extra dollars that they could use to fund a technology infrastructure. So CMS set this up under IBH, where each state, as Dan said, gets $7.5 million per state. And the allowable uses of those dollars in the IBH program include adopting and upgrading electronic health records, adopting interoperability solutions, and that can be inclusive of covering the costs, the fees that are associated with health information exchange participation, which is sometimes a barrier for organizations wanting to use the HIE as their interoperability source, but can't afford the fees. And then finally, tools for screening and tracking physical health conditions and health-related social needs within the IBH participating providers, behavioral health providers in that program. On the CCBHC side, the IT piece is a little bit more fuzzy. It does have requirements that participating providers must be able to achieve, but if you're only in the grant program, it's a little bit more difficult to come up with an innovative funding source to pay for that IT infrastructure. If you're in the Medicaid PPS, prospective payment model, you load those IT costs into your prospective payment and then get, based on a 12-month budget, and then get it paid out on the monthly basis. And the types of technology that CCBHCs have mostly spent money on has been enhanced tech for tracking outcomes and health-related social needs. And then about 50% of them has spent dollars on EHR upgrades or fees to participate in health information exchange. Next slide, please. I just wanted to briefly highlight the role of technology. Includes things like looking at remote and virtual service delivery. It definitely includes your electronic health records. You can have it include mobile applications and wearables if that's something you wanted to include in your plan. And then absolutely those interoperability solutions, because you will need those in order to be able to receive data across a whole spectrum of providers and settings that are actually touching your patient when they're not in front of you in your clinic. So again, it's the hospital emergency departments, it's public health organizations, it's hospitals, and then finally data analytics and predictive modeling. Next slide, please. So as we work with, next slide, please. Yes, as we work, no, you're going backwards. As we work with clients at Open Minds, next slide, please. Next slide. Thank you. As we work with providers, specialty care providers, and others who are in the planning stage or have started to implement a whole person care practice and really want to take a look at what would be a comprehensive technology plan for my organizations, these are the kinds of applications and common technology tools and platforms we see them adopting. A couple that I would just like to highlight, the third-party data integration, that's synonymous with interoperability. You have an ability to bring in data from external to your electronic health record and have it integrated in your record so that you have a complete picture of the health journey of this particular client. We also mentioned virtual solutions. Of course, we have telehealth on here, care coordination software and platforms. If you're not going to focus on just having staff members who go out and do that complex care coordination or that transition care coordination, platforms can help facilitate some of that on behalf of the provider. And then finally, in more advanced behavioral health practices that are using either CCBHC or IBH, you actually find a lot of organizations adopting full-blown population health platforms that integrate with their EHR and produce all the data analytics and reporting that allows you to, identify a group of high-risk members or risk score members, or identify current gaps in care that the treatment team wants to be paying attention to with the person. And then the last slide, just kind of wrapping this all up in terms of just the key takeaways for both evidence-based practices and technology, is you really want to be thoughtful about what evidence-based practices you select for implementing in your whole person care model, because it does take some work, sort of not only building the plan, but implementing the plan and making sure that staff are fully trained to the fidelity of what that evidence-based practice is, so you can accomplish the health outcomes that are associated with that particular model. So be thoughtful about that. Also have a technology plan alongside your plan for how we're going to get primary care into the mix with behavioral health, because integrated technology in the long run is what's going to make your practice be successful. We definitely think about what collaborative partnerships we can put in place. In some situations, that might be collaborating with community primary care practices if your whole person care model does not deliver the primary care itself. But that's a key relationship you need to have in place, because you have to have organizations to refer your patients to that where you have identified common health conditions or more serious health conditions that need primary care intervention. And then finally, prioritizing staff development at all levels of your planning model for whole person care, because staff are one of the critical pieces to making all of this work. Next slide, please. We've got just a couple of minutes before I'm going to move to questions from the audience, but I did just want to talk just real briefly about the Open Minds integration readiness assessment. And I've been kind of referring to pieces of this in staffing and technology as we've gone along. This is a process we really use to support specialty care providers in planning and implementing a whole person care practice approach. And it really starts with understanding the market that you are in, your local healthcare market, and what is a model that would be a best fit there, so that you can position your practice in such a way that you'll have long-term success. And it goes all the way at the other end of the arrow to a financial feasibility assessment component, usually involving developing a pro forma, the 3-year out look-see at what costs are going to look like and expected revenues, and to give you the ability to stress test your whole person care approach. So next slide, please. I'm going to go through these very quickly so we can get to questions. When we do market analysis, for those of you who want to go down that road yourself, these are the kinds of factors that we look at. Who do you serve? What do the people that you serve actually need? Who would most benefit from an integrated care program? Because maybe you're only going to do it for a piece of your patient population. And where do those people who you've identified as most needing whole person care, where are they currently going to get their health care? So in many situations, they're not going anywhere at all, which is great because you can, well, it's not good, but you can easily step in as the primary care provider. But for people that are already in a relationship with a PCP, usually we don't try to disrupt longstanding healthcare relationships. So that's identifying where those PCP practices are, where you might need to establish a collaborative partnership, or just find out if the people, they might not be going. So are they willing to switch to your integrated services? And then really we look at growth. Who are those complex members, the 10% that utilize 70% of services? That's a great population for focus. Who is missing? Who's not even in the data because they don't show up for care, but they're in your community and they need care. So who's underserved? And then where really are those treatment gaps? Next slide, please. And then just real quickly, we usually like to look at, what's the competition up to? That's, I always found, one of the more interesting questions to answer in market analysis, because you want to be able to distinguish yourself. You want to be able to have a successful model that's branded for you and distinct. So from any competitor in your area that's delivering whole person care, and then just remembering that those organizations don't always have to have a physical footprint in your service area, because they may be a virtual solution. And then of course, and maybe in some ways even most important, is to have a conversation with your payers or health plans about what are they interested in seeing being developed in terms of whole person care models in the area that is part of their catchment. You want to leverage those health plan relationships and any trending data that they have to see who are their populations of great interest or niches that cry out for an organization, a thoughtful, well-organized whole person care practice to step into and to serve those individuals in very unique ways. Next slide, please. Oh, there's more. So, just part of the process is to help you decide on what kind of model makes the most sense for you. And then in terms of the staffing, how are we going to get there? What are the staffing gaps that you will have? What are the roles that need to be fulfilled? We've talked about several during this presentation, but truthfully, one of the core ones is making the choice about how you want to deliver the primary care component of whole person care, through a partnership, through a partial integration model, or through a full integration model. And questions that go along with that are, what would it be virtual or hybrid? Will these be contracted staff, or would they be employed? Next slide, please. Regardless of what kind of model, IBH, CCBHC, patient-centered medical home, any of the 80+ ones we showed on that grid right at the beginning, this is what's common to all whole person care programs from the practice perspective. There'll always be team-based care. There'll always be some type of universal screening, will be or should be. There's always information sharing, screening for social risk conditions, and referral to community-based organizations to resolve housing, food, transportation issues. And then really that individualized person-centered care that brings family members and caregivers into the treatment plan to be part of that treatment partnership with the person. And I think this is our last slide. Oh, just as a reminder, another way to get to all this, instead of building it yourself, is actually go out and buy it, or find a like-minded organization that you would merge with. These are great strategies. They're not for everyone, but these are great strategies to get to immediate scale in delivering whole person care, and then having those additional resources needed in order to be able to build out the population health, the staffing pieces, the expanding geographic reach, etc. Next slide, please. Domains in the Open Minds integrated readiness assessment. We talked about the first one, model market and financial feasibility, but we also review leadership, commitment, and the culture of integration in your organization with advice and steps on how to advance all those, this financial planning and management, the care delivery model and how care coordination will work in your program. And then what's your information systems platform? What does that look like, and what do you need to add to that or bring in as tools in order to advance to where you want to be on the technology side of things? And then, as I just mentioned, patient, family, and community engagement. Next slide, please. So at the end, Open Minds Integration Readiness Assessment helps you build a roadmap to either implement a whole person care strategy, or if you are already delivering whole person integrated care, how do we take a look at that and identify the points where it can be optimized or improved to really advance really accelerate you down the road to making that happen. And I think with that, thank you. Yes, thank you. We were just going to move. I think, Dan, if you're still there, we're down to only a few minutes for questions. So just wanted to see if there's any questions out there. And whether Dan's there. There she is.
Yes, Christy and Dan, thank you. We did get a couple questions.
Okay.
And we are limited on time. I apologize to everybody for the
Yes.
slight hiccup we had with the software. So we had a question come in. It says, outcome measurement based only on HEDIS often miss meaningful behavioral health outcomes. What opportunities are there to expand outcome measurement to behavioral health specific measures?
Sure. I can add a few points, Dan, and if you want to take it from there. Two things. If we're talking specifically about the IBH program, those HEDIS measures will be evolving over time. So the selection of measures that we showed earlier is what was in the notice of funding opportunity. That's where the thinking is today. It'll be 3 years before implementation of IBH starts. And I have no doubt that there'll be some modifications, additions, and adjustments to the HEDIS measures that will be selected between now and then. But the second point is, and you'll actually see, we had an executive briefing on this just last week, is that NCQA themselves in August actually made adjustments to some of the behavioral health HEDIS measures, recognizing that the measures are not 100% great for capturing the type of activity that occurs and the type of outcomes that occur in behavioral health. So there are adjustments to the behavioral health HEDIS measures. If you go on the NCQA website, you can read all about the details there and see the technical specs. Was there anything you wanted to add, Deanne?
No, I think you covered it all. I think we'll all stay tuned to see how we can build in those areas.
Yeah, for sure. Anything else, Corey?
Yeah, that was great, guys. Thank you. And the last question that we got from the audience was, does CMS see the CCBHC and IBH models as complementary models, or rather as an either or, depending on the state?
Absolutely complementary. So in this IBH NOVA, IBH program notice of funding opportunity, it specifically lists CCBHC as organizations that can be involved in both models. And there's actually some complementary, would be actually a very good place for you to be from the funding side, because you can actually bill for primary care, as well as from the operations side. Deanne, do you want to add to that? Just
I agree with what you're saying, Christy. I think that, you know, specifically speaking to the primary care funding, you know, we have a lot of questions towards many of the models. They don't pay for the primary care. So when you're looking at getting payment for those, there's braided funding across the several streams. That's a main strategy, and using Medicaid funding to deliver the actual treatment services for both behavioral health and physical health can be used so long as the client is Medicaid eligible.
Well, I want to thank you both again, Christy,
Yes.
Deanne. I want to extra thank Deanne, who went the extra mile to join us today and make this happen. And I want to thank everybody in the audience who joined us. We're at the top of the hour now. And I want to remind everybody that the slides and the recording for this will be made available on the Open Minds website starting tomorrow. And I also want to take an opportunity to invite you to join us next week, Thursday, October 10th, at 1 p.m. Eastern, when we have another roundtable, Implementing Value-Based Service Lines, the Mainstay Life Services case study. You can register for that event, or for a full list of upcoming roundtables, you can visit our Executive Roundtables page, which is located under the Executive Education tab at www.openminds.com. Christy, Dan, thank you very much. Today's been great, and you have wrapped up our 3-part integrated care series for the year. Hopefully we see you next year.
Thank you. Thank you.
Thank you, Corey.
Bye now.